This is Sg2 Perspectives, a weekly conversation between the Sg2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode.
AI is great, but the labor shortage is going to get here faster than AI will make a productivity impact. Are you in that market and what do you do right now versus a market that's just younger and generally healthier and has overall supply and a little bit more timeline and wiggle room?
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. I have my co-host, Jayme Zage, with me, as well as Brian Esser, all from the Sg2 intelligence team. We wanted to recreate an in-the-office discussion. All of us in the healthcare industry are probably inundated with newsletters, pushes to our emails, stuff we flag and pay attention to. We wanted to go through some recent articles that made our ears perk up and share our opinions and key takeaways. And is it a signal? Is it noise? Is it a trend? Is it a one-off? Jayme, Brian, thanks so much for joining. The first one I read. The president of AHA said last week that they were going to really lean on technology to focus on healthcare affordability. They zeroed in on a few ways they were going to do that. My initial response was a little bit of skepticism. But if we're hearing that other places, maybe it's real. They didn't really talk about AI as the biggest driver of that. Brian, what was your immediate reaction?
Cost continues to be a key factor. We see all the different surveys are starting to come out as far as how much healthcare costs are going to escalate this coming year. Here at Vizient, we do our own cost projections, particularly within our supply and spend management side. In aggregate, on the pharmacy side, at the end of the day, the story remains healthcare is expensive and it is going to continue to grow in expense year after year, likely at a pace that outstrips inflation or wages. How do we bend the cost curve? That's what health systems are after. The other side of that is the reflection on an insurance basis. Our governmental and uninsured book of business is growing, so our revenue quality is diminishing and margins are getting tighter. So cost is the area we need to focus on and streamline if we want margins to remain somewhat healthy on a go-forward basis. I'm not surprised by the headline. That makes sense. One thing that we're doing here is really kicking the tires on value. And what does that mean in 2026 and beyond? Trevor, you were doing work on CINs and ACOs. What's changed? What's not changed? Still feels care management, care coordination, preventing patients from escalating up the cost curve into higher acuity when we can get ahead of that care is important. My question would be, how do we infuse some of the new age AI, new tech to build upon some of those value infrastructures that we have built out in the past in entities like CINs and say, okay, all that matters, yes, but the next stage is a technology infused way of delivering care that's more cost effective, more timely, and maybe more engaging for the patient.
Talking about care coordination, Brian, that's really hitting where the biggest bang for the buck is in terms of AI and some of the other technology. It's about shifting where patients are cared for at what stage of the disease. So it's a lower cost of care situation overall. It's not even just a lower cost setting, but it's at a stage of the disease where the price of care is much less, preventing the ED visits, preventing the avoidable admissions, or preventing admissions because now you've avoided the condition that would require an admission. Those are some of the things technology is doing, and we're seeing that with early triage, being able to engage patients between visits to manage symptoms, to better capture and connect them to some of those lesser acute providers for early intervention. That's potentially one of the things that we're starting to see some roll up in. Now, for health systems, the part of the conversation is the value to the health system and lower cost of care and delivering it to the patient and the payer. For the health system side, AI is still trying to figure out how to create its own ROI.
I'm maybe more skeptical than the two of you. There was another article I saw was talking about employers pushing back really hard on increasing healthcare costs. And it's like, was this a 2015 article? That's been every year for the last 10 years. And there's no big coalition that's making an impact. They could and should, but let's see if this just feels like incremental change or something really big. Every time a new hospital health system ranking comes out, there's just as many articles saying, do these rankings really matter? What's the point? There's an article looking at some of the metrics and key pieces and saying, are health systems really improving or are they chasing the metrics and the scores? Having been at a health system that cared a lot about US News and World Report rankings and put a lot of time and energy into it, things were really important to a lot of people there. And they felt like it could move market share on tertiary and quaternary cases. And they felt like it was a huge part of their value proposition. But was it really worth the amount of time and energy we were putting into it? I'm not sure. Jayme, Vizient obviously has a very clinical and operational focused Q&A score. Members put a lot of stock in. What do you think overall about rankings, and are they worth the squeeze?
I have this debate with my son all the time about rankings. He ranks all the roller coasters he's ridden. He's up to almost 100 roller coasters. And we talk about the subjective component of why are you ranking them this way? And he's like, well, if I rank them based on theming versus intensity, it's a different list. I bring that up because what is the ranking measuring? And it goes back to what are the measures that are most valuable that really have an impact on what we're trying to do as a healthcare ecosystem. It could be that we're talking about outcomes and quality and performance, or it could be that we're just talking about reputation. And that reputation could be built on scientific advancements and innovation. And so that's not necessarily a bad thing. It's just a different perspective. At Vizient, we have the Vizient Quality and Accountability Index, and that takes into account mortality rates, patient-centered care, safety, efficacy, efficiency, and looks across all those domains in terms of how we deliver the care. That has become, for many of our hospitals who are part of our clinical database program at Vizient, that is how they continue to benchmark themselves, and they look to improve on that. Recent data that we did in collaboration with some of our Vizient colleagues, and this has been published pretty widely now, is that depending on where you fall in that Vizient quality and accountability ranking system, there's a very different financial outlook when you look at the cohorts, the quintiles of that. If you're at the top, you're probably getting a better financial situation than if you're at the bottom. That gets to the what's the impact on the health system perspective that we were just talking about before. Brian, what do you think?
I agree with both of you. Rankings matter, and we all want to know where we stack up amongst our peers. But which ranking tool you put stock in is telling. And it's interesting because the C-suites and the boards use rankings as a barometer of how are we ultimately doing. The board wants to see movement across these rankings. Jayme, I'll go to your discussion around the clinical database. I'm a staunch believer that if we're going to fulfill our mission, how well we deliver quality and outcomes needs to be first. That's why the clinical database is so widely used across all of the hospital cohorts. And the beauty of it is you can look at yourself as compared to your academic peers, if you're an AMC, or your independent community hospitals. And you can think about, how do I stack up against these peers in a meaningful way? And what levers do I need to pull to really fulfill the mission? But then the hard part comes in saying, hey, my consumers don't know the Vizient clinical database. They know US News and World Reports. How do you translate our performance in a ranking system that is more meaningful to a way that the consumer says, oh, I see the value in doing it that way, and I understand why you're so focused there. So there is that little bit of a disconnect of translating how much you're working on quality to prove the overall value of the product to the consumers in your market.
Trevor, I know you read a lot on Medicare Advantage. You've been doing a lot of research in that space. I just saw an article recently that looked at average length of stay for Medicare Advantage patients versus traditional fee-for-service. And average length of stay was higher in Medicare Advantage patients. It's, again, higher cost to the healthcare system. And coupled with the ongoing on-again, off-again relationship that a lot of hospitals have with Medicare Advantage, where they're refusing to contract with Medicare Advantage, and that's causing some disruptions. But they're doing that in part because of the higher costs or higher administrative burden, lower reimbursement, all of that. But what are you seeing in Medicare Advantage, and how is that starting to pan out with some of the articles you've been reading?
It's kind of promising. I saw an article about a big coalition of some monster health systems coming together. And they list this specifically. They said legislative perspective. And their goal is, let's get in the room, CMS, payers, and big representatives of big health systems. Because their goal is not to get rid of Medicare Advantage. It's, we should make this work really well for patients. We know this is the growing and probably the biggest at most of these health systems and hospitals segment of patients we deal with. It's also an admission, though, that if we don't do this, it's an acknowledgement that we have more levers than we probably thought and have used to push back on payers. We're seeing more and more health systems willing to go to term with one or two of their least cooperative payers. The expectation is we'll be out of network for a cycle, we'll negotiate, we'll get to a good place. Health systems are going to take a harder line. They're going to have tougher demands on payers to make it worthwhile to stay in network. That's a really good thing. So I was hopeful to see some health systems putting their heads together to say, actually, we have some agency here to push back, and we could and should.
It feels like the tenor around Medicare Advantage has shifted over the last 18 months. To your point, Trevor, the realization that there is power amongst the provider set, they're willing to use that power, but they also know what they're looking for. Just going to the mat to say this isn't working is not specific enough. Using data amongst themselves within the system, but then across peers. And Vizient runs a fantastic CFO network where I'm hearing a lot more mutual discussion around what's working, what's not as it relates to denials, and what are the right benchmarks and baselines, and how do you really stack up your payers against each other and say, hey, you're an outlier. We need to have a discussion. And then being willing to use the data in a much more proactive way is good. I think that's where we need to be. And it gives the payer at least a chance to react, if nothing else, versus a straight up termination letter every time.
Yeah, agreed. Taking a different angle, something I sometimes avoid because it's so complicated is workforce. And it's the problem that sort of never goes away. I heard Bill Wilson say in the last 5 years could be described as we made great progress on workforce, and the next 5 we're going to have to keep making huge progress on workforce. HCA acquired a healthcare professionals college. That's pretty exciting. It's a big move. That's going to change their pipeline. That would make me nervous if I was a health system who was in a market and was a direct competitor with HCA, and we had been drawing from that talent pool from this professionals college. And it would make me hopeful if I was running an HCA hospital, I'd have a better, more consistent pool of talent for everything but physicians. So it's a super smart move. And it jumped out to me as, well, this makes a lot of sense. This is an awful good idea.
I saw a couple different spins on workforce. One of the things that I saw was actually interesting, specific to academic medical centers, was to really look hard at their residency programs and their residency slots. And to be more strategic, they're allotted a certain number of residency slots. Are they strategically deploy them to the places where they really need the extra workforce, as well as can drive additional revenue? That might cause some imbalances across the country in terms of where we're going, but it's asking these academic medical centers to really think strategically and longer term about what is the residency workforce requirements, what's going to be needed for the future of delivering care. It's a little bit more strategic look at that training portion of it from the academic medical center. That was an interesting insight into how to think differently about the training programs.
Training programs are going to be needed. I think you have to bolster this even more so, Trevor, to your point around HCA and really a grassroots all the way down to high school, maybe grade school levels. All of that continues to matter. We've all been pursuing that for a while. Workforce is one, so I've never really taken it on aggressively since being here at Sg2. If you look at the labor data, healthcare continues to be one of the sectors that continues to hire. We're supporting across the entire country. A lot of hiring continues to go into the healthcare space. So we're attracting talent. That's good. But if you look outwards and within our work for our tool that we call the economic index, a couple of colleagues of mine, we've added a new ratio that gets down into a pretty, at hospital referral region level, what we call the potential support ratio. And it's assessing over the next 5 years, the portion of your community that is retirement age versus working age. What is your ratio? If you're below 2, you're likely going to run into just a labor supply crunch, regardless of industry. You just don't have enough workers for all of your retirees. Think about Naples, Florida, those kind of environments where there's a lot of retirees. What do? If you don't have the supply and you're competing for any of those workers across all sectors in your community, you're going to see either wage escalation rise, therefore your margins are compressed, or you're just going to run out of potential workers for healthcare. We need to understand not only what's happening today, but project out where is there going to be a dearth of just labor supply, and can we get there faster than when AI will have an impact? I saw a quote from the CEO of Indeed, a staffing firm, saying at the end of the day, AI is great, but the labor shortage is going to get here faster than AI will make a productivity impact. Are you in that market, and what do you do right now versus a market that's just younger and generally healthier and has overall supply and a little bit more timeline and wiggle room? That's the real debate that I'm trying to figure out. When does that hit? And it's probably going to hit in pockets over the next 5 to 10 years.
That's interesting because one of the other articles I read related to technicians, those sort of ancillary staff, was the concept of doing an apprentice program. They get minimal training up front, but then they're really getting on the job training. And what that can, and it's full pay, it accelerates their ability to get into the workforce to deliver on those needed staff elements as well. And so that's another little interesting thing that might help accelerate getting, if you've got the younger population that you can draw from. Obviously, that's not going to fly in the retiree population.
Not at all. And just think about all those non-clinical folks, Jayme. The wage bands they're sitting at are also wage bands that Amazon's going to compete for and your retailer down the street might compete for. So you're not just competing within healthcare and health systems, you're competing across industry for your people doing the general work.
It's such a paradox, but was with the health system last week. We're talking all about their mission, their obligation to the community, how much they want to really focus on the services their community relies on them for. And then they talked about how scared they are that a new standard minimum wage is going to pass at the state level. Because, yes, of course, they see the big picture impact, but they know how much it's going to make an immediate financial impact for them. Couldn't help but feel like those two things were in opposition. GoodRx rolled out a subscription program. When I read it at first, I said, one, they didn't have that already. And two, it feels like they're 5 years too late. But then when I thought about it more, it's like, no, it's different than maybe some of the other pieces or competitors because they already have a reliable product and they must already have pretty consistent customer base who has stuck with them through Amazon or whatever other direct-to-consumer options have been marketed and become available. And this was really saying to me, actually, this is a way to just get stickier with those customers who they must already be sticky with because GoodRx has weathered the last 5 years of storm disruption and options in that market. So actually, at the end, my takeaway is this is probably an okay move and is probably telling us that they see kind of a consistent customer base and they think they can shore it up and expand the services for that group rather than try to grow and expand their customer base. Not as bad as I initially thought. You guys have the same read or do you think something different?
Well, it just goes to show from a consumer perspective, access to cost-effective medications matters. And if you have an organization like GoodRx or others that you trust, you've been with for a while, you're willing to sign up and say, yeah, I'll do this on a subscription basis. You can count on me as a consumer and I'll be loyal to you. Nothing that our providers can't repeat or replicate. We just need to understand what does that business model look like and are we willing to drop into a potentially different model than we have been in the past. And also that pharmacy as a strategic lever that we've talked about in this podcast several times continues to grow. It's out there and it's not all the things you need for when you're sick, but this idea of wellness is a multi-billion-dollar area. What do you want to do there? How do you think about that continues to bubble up and getting to the consumers where they want to be met, not just when they show up at your door, but before they do that and getting into their world much more aggressively.
Brian, you can immediately see the layers that GoodRx will put in place. They'll try to own more of that consumer relationship. And as we know, more and more of that relationship is around access to and management of therapeutics. So I think it makes sense. Thanks so much for getting your reactions. That was a long elevator ride for the three of us, but glad we got to chat.
Good stuff. Good to see you guys.
Good to see you too.
Thanks for listening to this episode of Sg2 Perspectives. Please don't hesitate to reach out to Sg2 if you have questions or suggestions for future episodes.